First, let me introduce today's speaker, and we are honored to have Dr. Ochoa as today's speaker. Dr. Juan Ochoa is the director of the Comprehensive Epilepsy Program at the Frederick Whiddon College of Medicine at the University of South Alabama. His clinical interests including clinical neurophysiology and epilepsy surgery evaluations. And his current research interests include advanced seizure source localization and high-frequency brain activity associated with the seizures. Dr. Ochoa has a rich experience in electrical source imaging in both research and clinical practices. His talk today discusses the epilepsy from neurons to network levels. Dr. Ochoa, the floor is yours.
Thank you, Wade. It's my pleasure to present today at here NeuroTalks. What we got talking today, we're going to a little bit to the basics of what the EEG is. I'm going to the base from the neuron networks to explain how the EEG looks and how epilepsy happens. So as per disclosures, I am a speaker for Compumedics. I'm a trainer for Curry and also have been a speaker for Cadwell as well. So the main objectives of this talk is to review the epileptic microcircuits and how these networks apply to EEG and how this goes to epileptic EEG explanation based on this. All right, so the first thing is that when you look at the EEG, look at the squiggle lines, whoever not a neurophysiologist, look at this, the squiggle lines and what that represent. And the EEG is a great tool to actually see what the brain is doing at a given time. And to make sense of these squiggle lines, this cartoon is very important. It depicts each dot here with a neuronal spike. And so as a spike in neuronal means depolarization. It means that the sodium channel is open, you have acute depolarization, you have a negative potential, and this is the little spikes. The little spikes are each dot here. When the neurons are connected in a network, then the neurons fires in a pattern, and the pattern goes typically on, off at various frequencies. When you have a group of neuron firing on multiple spikes, and if you're going to look at the local field potential, you will see the potentials go up and down in an oscillatory manner, and that's what we actually could see on the EEG is the representation of this oscillatory depolarization of the neurons in the network. So the EEG is composed of multiple frequencies. You have a slow frequencies we call a delta wave, and I'm going to try to be as genetic and basic as possible, so I'm not sure about the audience training, so just forgive me if I'm too simple or I'm too complex. All right, I'm trying to do a little bit of broad explanation. So the slow waves in the delta range and the fast waves are in the beta gamma range. That's typically range that we see on the scalp EEG. So how the brain gonna depict either a slow wave or a fast wave, it all depends on the local network or the network involved in this. So this is from physics, the basic of it. If you have a small network, a slow frequency won't be able to go through. So the output of the small network will be only fast frequency. In this case, you depict the F3, which is the fast frequency. if you have a medium-sized network, the frequency of the oscillatory activity has to be in the medium frequency range. And a very large network, the only output that this network is capable of producing is only a slow frequency waves. So when you see your EEG, you will see a composition of multiple frequencies. Here on the left side, you have an example of the alpha rhythm. It is T501, T602, and would appear to be a sort of sinusoidal waveform around, typically around the alpha frequency of the alpha rhythms between 8 to 12. So you use around 9 hertz here. So it seems to have a fairly regular rhythmic pattern that you see normally in the alpha rhythm. Now, if you spread this out, so this is 200 milliseconds. Now, spread this out, this 200 milliseconds. And you open the high frequency filters to allow the high frequencies to go in. So indeed, every oscillation here that appears to be smooth when you increase the amplitude and spread it out and remove the filters is composed of very fast local activity. So you see the fast local activity, but you see also the slower activity of the alpha rhythm. And that's applied for every waveform that we see on the EEG. So how that happens and how the brain regulates its frequencies, it depends of the network connections and how the network works. And our brain has the awake and the sleep states, all right? When you are asleep, the cortical networks, which are the small networks, are dormant, are not active, whereas the thalamocortical networks are very potent, very powerful. So as a result, you generate a predominant, very large network involving both cortical regions, thalamus, bilaterally. So in the real EEG, you will see delta waves, and the deeper the sleep, the slower it is. So you have different stages of sleep, depends of the degree of this thalamocortical network intensity and the suppression of the local cortical network. All right. And if we do this patient during the awake state, this thalamocortical network become very small, and with the predominance of the cortical networks very strong. Again, remember the small networks only allow to produce fast frequencies. As a result, you will see a low voltage beta that you see during the wake background. All right. So with this, we'll be able to understand, okay, now these squiggle lines make some sense. We have some slow waves that represent large networks, and we have fast low voltage waves that represent small networks. All right. So this is an example of an EEG. In the left side, you see a wake state with the eyes open. So the eyes open means that the background is going to be low voltage beta activity. The posterior cortex is going to be engaged because you have a eye stimulation, all the calcarine cortex and all this is activating this cortex that it has these very small local networks. The product of these local networks oscillatory activity is in the beta range. Now, if we close our eyes, and that happened in the second part of the EEG, what happens, anteriorly we still can have the low activity, but posteriorly, this cortex becomes inactivated because there is no eye, there's no light, there is no visual input. So this calcarine cortex gets regulated by the lateral geniculate nucleus of the thalamus bilaterally. So you get bilateral thalamocortical network. This thalamocortical network has oscillatory activity between 8 to 12 hertz. That's why the alpha rhythm, you're required to be awake, you're required to have the eyes closed, and you need to be relaxed to have this beautiful alpha activity. All right. So based on the state of the patient is awake, or the patient is asleep, or the patient has the eyes open, or the patient is relaxing, or the patient is um, uh, stressed out, or it's going to change the activation of local network versus large thalamocortical networks, and that's what the EEG is going to show you. So you could really tell when a patient is awake or asleep with the EEG. You have in a sleep state, you see the predominant is theta and delta activity and drowsiness. In the stage 2, you get the spindle activity that is probably some motor cortex, premotor, motor cortex, and thalamus. Similarly, what you see on awake, you see the mu rhythm, and in sleep, you see the spindles, and you see hypersynchronization of the both multiple cortex areas, and those the vertex waves, they're large sharp waves that are associated with hypersynchronization of the thalamocortical networks. So the amplitude, and this large voltage, is because the amplitude is proportional to the degree of synchronization. The more synchronized the EEG, the larger the amplitude. Okay. So you could basically, by looking at the EEG, you know the patient is awake, you know the patient is asleep, and obviously then you start looking into abnormalities. So this is all normal EEG. So now what happens when you have something wrong with the brain? And I'm going to give you an example. You have a lesion in the temporal lobe. There's a mass lesion there. You see a lot of atrophy and damage of the anterior left anterior temporal cortex. All right. So what's going to happen is if you compare the networks in the left compared to the networks in the right, the network in the right has these small cortical connections. And if you look here in green at the bottom in the average, so this one has average reference. So you will see, you know, this patient is awake with the eyes closed because we see the alpha rhythm. And we know it's awake, you have the predominant pattern is low voltage beta anteriorly. All right. You look in the temporal cortex, in the right side is low voltage beta activity. But when you look in the left, you see predominantly delta. All right. And what happens is this cortex that is damaged lose the ability to activate cortical networks to create the fast activity consistently. And therefore, the thalamocortical networks are going to take place, and then you're going to see a local focal delta slowing because this area loses the ability to produce cortical network activity. All right. So sort of it's like this focal area of the cortex become dormant. Just only this, the rest of the brain is awake. So that's when you see focal slowing on the EEG. All right. So focal slowing represent a damage of the gray-white matter in one region of the brain, okay, affecting the cortical connectivity in that area. You can have both hypersynchronization and slowing. So if this area, here you see the hippocampus typically coordinate this area, but if this area has low cortical activity, but it allows to be hypersynchronous with the hippocampus, you can have a spike. You see here a spike, and you call it a spike because of the morphology. You see a very sharp point followed by a slow wave. The sharp point represents the depolarization fast of the region. The amplitude of this depolarization is proportional to the amount of cortex that is depolarized fast. And then once it depolarized, then gets the process of repolarization. And repolarization is a slow process, an active process. You use the sodium-potassium pump, and whereas depolarization is simply opening of a channel. So what's depolarization? You see a sharp wave or a spike, and repolarization, you see a delta wave. So a spike and a slow wave is what typically happens when you have hypersynchronous activity in one area of the brain. So why this hypersynchrony happening? This hypersynchrony happens because there are some problems with the microcircuits of the brain. These microcircuits are very important to determine the control of the regulation of the brain activity. And there are 4 types of dysfunction of the microcircuit that are prone to develop epileptic activity. We have feed-forward inhibition, feedback inhibition, counter inhibition, and recurrent excitation. All right. So the counter inhibition, and is it not the same in every part of the brain. And here we compare the counter inhibition in the hippocampus versus the thalamus. All right. So you see the parvocellular cells, basket cells in the hippocampus. There are inhibitory cells and produce inhibition of other inhibitory cells. All right. So when you boost this inhibition of the inhibition, what happens, the net result is this inhibition of the downstream excitatory cells. So in the hippocampus, you have this damage of this when you have too much inhibition of the inhibitory circuitry. You create a oscillatory gamma activity on the hippocampus, hyper gamma ripple activity on the hippocampus. Now, in the thalamus, you have to do sort of the opposite, because the circuitry of the thalamus, you have the reticular nucleus of the thalamus, the main GABAergic nucleus of the thalamus, produce an inhibitory effect of the inhibition. All right. So this counter inhibition, if it's blocked, with actually when you have too much activity, what basically it does is the opposite. So you see here an example of a GABAergic when you have the counter inhibition affected, and then that's why you get worsening of the of the activation of the circuitries with the thalamus in the opposite way. Other mechanism that we see is the feed-forward inhibition. All right, and you have in the cerebral cortex, you have these inhibitory cells. All right, that inhibit the pyramid cells and control the output of the pyramid cells. But this inhibitory cells also control another interneurons that also can stimulate the inhibitory cells. So the feed forward inhibition means that the actual inhibitory effect of the excitation of the thalamocortical networks coming in is going to be decreased, because and it goes decreased, eventually the net result is less inhibition to the pyramidal cells, and you're going to have hyper excitation. In the thalamus work in thalamocortical networks, get the feedback excitation, and when you get decreased that excitation, you increase the activity of the inhibitory cells, and then you overall you're going to decrease the inhibition of the recurrent excitation from these thalamocortical neurons. All right, so that effective feed-forward inhibition eventually going to increase the activity of the network. The feedback inhibition, it's the more simpler. You see neuron spike. All right, the spike gets a inhibitory feedback and then stop it. If you damage the inhibitory feedback, then you get a what's called a paroxysmal depolarization shift, where we have multiple spikes together, and that's sort of the precursors of a seizure. All right. In the thalamus, if you have a boost of the inhibitory activity of this thalamocortical network, it's going to suppress the inhibition. So it is going to be suppressing the seizure. All right. The other mechanism is recurrent excitation. So a pyramidal cells is going to excitate the next one and the next one. And so this is going to have recurrent boosting the activity of the neurons. And that's we typically see when you have cortical injury, then you have recurrent excitation of these neurons, and then you have that in cortical dysplasia well. And that's why those networks are highly epileptogenic. All right. So all these networks, what it's going to do eventually is going to enhance the excitability of the network. All right. So you can have an epileptic network, a focal epileptic network, but that's not going to be able to cause a seizure. You require this local network to communicate with a neuron that is susceptible. Means this other neuron has a low threshold, has some sort of abnormality of this network that has low inhibition, a high excitation, that eventually this seizure onset can pick other epileptic neurons in different networks that eventually will recruit this network together. So the higher the network, the higher the source. And the higher the source that this, let's say in this case, this frontal network that was previously normal, it may be normal, but if the source of the network that is creating the epileptic activity is big enough, eventually you can create a larger local network that can generate the spike or a seizure. All right. With EEG source, you could look at the current density. The current density implies the density of dipoles that are depolarized and represent an cortical activity. So this is an example of a cortical network of a spike. What you see in yellow, it's color coded here. Yellow means the higher density of dipole generated, and black would be the less dense. So the higher activity is in yellow. And as you see, this patient had this prior lesion in the temporal lobe. You see a spike. You see what area of the spike is of the cortical of the cortical of the cortex is firing. All right. So with the scalp EEG source, you could depict what is the likelihood of these dipoles are concentrated. And you could potentially, if you look here, you see a spike. I'm going to put here of the timeline. As you go the timeline through the spike and the slow wave, you could see how this concentration of dipole moves during the spikes. So it can give you an idea of let me see how it works. Yeah. So now you see start working of the firing of the spike at the temporal cortex, get involvement of areas in the orbitofrontal cortex, the lateral cortex, and all these areas that get recruited for this spike to have this activity. So you can see how much of the cortex is being recruited, eventually spreading to the orbitofrontal cortex. So with this technique, you could potentially deduct the areas that are firing at the beginning of the spike and how this activity cortex recruit or neighboring cortex to make a larger spike and larger activity. So when you look at an EEG, the EEG basically going to show the spikes. The spikes is a little local hypersynchrony, as I showed you before, all right? And in this case is in the right temporal region. You see between F8 and T4 is the localization, and you see the spikes become frequent and frequent and frequent. And start recruiting more cortical activity, it becomes stronger the surge and overcome other neurons and other cortical areas to become more synchronized. Then you start getting also in the front area. So it's temporal, and it get involving into the front as well. And as the seizure goes and the excitation goes stronger, it becomes faster. You see higher amplitude because the amplitude, remember, is synchronization. The amplitude means the area of the cortex that is recruited within the seizure is much larger, and it's continue and progressive to the point that either, you know, once you depolarize, you have to go to the repolarization process, and you wasted your electrolytes to the point that you not have enough recurrence of the electrolyte to maintain the seizure, and the inhibitory networks start kicking in around it to eventually fail. And once you fail this synchronization of those areas, then the seizure will stop. Okay. So with this, we can conclude that the EEG provides a time-sensitive cortical activity information. Based on the neurophysiology, we can explain the EEG findings depends on the type of network that are activated. So we can understand if this EEG is represented by a focal local network versus a large network, and implies what is not working. And this is and the EEG is very accurate to represent focal cortical activity, and using techniques like EEG source, you can help to identify this focus a little more accurately, and you can see more dynamic. Okay, so with this, I will conclude my presentation for today, and I'll be happy to answer any questions.
Thanks, Dr. Ochoa. So let's actually go to the Q&A session. Please type your questions in the question area, and my colleague, Dr. Kara Beckman, will actually collect the questions and read questions to Dr. Ochoa. Okay.
All right, we have a question. It says, great talk. This is strikingly similar to modern models of psychosis syndromes like schizophrenia and schizoaffective disorder. These models focus on similar neurotransmitters and receptors. Has the field of epilepsy tried antipsychotic medications like clozapine or glutamatergic agonists that act on these systems? What are the modern medications used to address these systems?
So although there are similar networks involved, particularly with psychiatric disorders and schizophrenia and all this, usually is involving of the cortex in a different way. So there is no evidence of hypersynchrony that has been associated with this psychiatric dysfunctions. So this that's why the networks involved in this are mostly associated with dopamine, whereas in epilepsy, the main neurotransmitters involved in epilepsy are GABA, glutamate, and obviously the main medication that work on that are sodium channel blockers. Saying that medication for epilepsy works on psychiatric disorders, and perhaps some of these shared mechanism, as you say, they have given some antipsychotic properties to some of the anti-epileptics. But this is a bridge that is not well understood. If you give antipsychotics to an epileptic patient, it's not going to help the seizures. But giving anti-epileptics to a psychiatric patient, yes, it can help the psychosis. So I think that some of the shared mechanisms are important, but the main state mechanism for the dysfunction is different.
Great, thank you. Another question, what networks determine if a seizure will remain focal or become generalized?
Yes, so it all has to do with the network's states. So, not every network are the same. Everybody has different level of threshold. So typically, our brain have at least 10-fold of inhibitory network compared to excitatory networks. So our brains are strongly inhibited, 10-fold. So for anybody who is not epileptic, it's very hard to go into a seizure. You probably need to produce a very severe stimulus, like, if you do electroshock, you put everybody in a seizure. But the threshold to get to there is pretty high. So it depends on the state of the networks of each patient is to determine whether this activity will be focal or generalized. There are certain networks in the brain that are more connected, like hippocampus, and it's very connected. So theoretically have a higher propensity to spread faster to another areas. Frontal lobes networks are highly connected, and they're commonly spread contralaterally very fast. Whereas the motor networks are simpler networks, and they're simpler in the sense that they're not as connected to us, and those are more likely to remain focal than spread to other areas. But it all depends on the state of the nervous cells around the neighbor, how good the inhibition is to prevent this propagation.
Okay. This question comes from Dr. Ran Paria from University of Buffalo. Excellent presentation. I would like to know that when you source localize S. loretta from scalp EEG, do you use specific parameters in Curie?
The main thing to do in Curie for S. loretta, the first you start with getting a good selection of the wave of the spike that you're going to source. You need to make sure they have, so Curie doesn't differentiate morphologies, only goes by amplitude. So you will have to make sure that you have a good signal to noise ratio before you do the current density sourcing. So you have to identify the spike that is has a good signal to noise ratio. They have no artifacts at the same time of the spike. So you'll be able to predict where it's coming from based on that. I typically use the S. loretta at 90–95% of the solution. I don't really care about beyond that because you're interested on the highest concentrated of dipoles. So that's sort of the main key points to get a good S. loretta source from the scalp.
All right, we have a couple more. Can we identify certain epileptic microcircuits with the scalp EEG or the intracranial EEG?
No, they're microscopical. You know, I don't think that what you basically see is the local network. And if you see an activity, particularly intracranial, you can see closer to that, but you not necessarily can see these microcircuits. You could see, there's some techniques that you could actually see that on research, right? And those have been done in dish models, where you can see the actual circuitry and you can visualize the difference, and you can see, for example, the sprouting of multi fibers in the hippocampus. They've been well known that they've been associated with these changes in these microcircuits. But in the EEG, you not be able to see that. You only see the spiking. You see too much spikes in one area. That means that area has changed microcircuitry. Also, you can see the propensity to a network or local focal cortical area to be induced into epileptic activity. When you do, for example, a stereo EEG and you stimulate, and you could have a seizure even as small as stimulus, mean that this area threshold for seizures is low. So you sort of test the threshold of these areas by response to stimulation.
All right, another one just came in. Certain antidepressants and anti-anxiety medications can lower the seizure threshold for a person. Is this strictly due to neurotransmitter changes, or is there any other network effect?
So typically SSRIs does not affect much of the seizure threshold. So this is commonly used in patients with epilepsy. They're working mainly to the serotonin networks. which has an impact on the epileptic network, but not as much. So I think the effect is minimal compared to the benefit associated with treatment. So I don't think that this is a major problem with those antidepressants. Particularly serotonergic drugs are usually safe to use.
All right, we had one more, and if anyone else has any other questions, feel free to type those into the question box. This question was, do you have any time frequency findings underpinning the corticothalamic models that you discussed? Are there some types of frequency band responses that can help to understand these types of connections? Like, is the communication primarily happening in the theta range or the gamma range or another frequency band?
So typically thalamocortical range are either alpha, theta, or delta range. Beta frequencies are typically represent cortical activity. And so sort of they're classical, thalamocortical networks or basal ganglia networks, like a mu rhythm is a basal ganglia with the premotor motor cortex activity. Like I explained in the talk, the alpha rhythm is the posterior thalamus and an alpha frequency. And then the rest of the frequency you see with this, because those ranges are so large, it could be either theta, delta range that you see in drowsiness and sleep. And so, yeah, so those are the main frequencies that you can sort of deduct that if you see an activity that is very slow, it's likely because the network is very large, and the largest network are usually thalamocortical networks.
We're going to jump back over to a more methodological question. What are the advantages of S-Loretta over the single dipole method?
So both are similar. The dipole model, it can give you similar information as the S-Loretta. They're basically looking at the same activity. The dipole model, you use a vector that have a direction, has the advantage of S-Loretta that give you directionality. So where you see the direction is where the direction of you get the head of the dipole, where you get the polarization, where you have the negative, and the positive end of the dipole is the direction of the action. So you can give you an idea of the directionality of the potentials. The second thing is dipoles are not represented typically in an anatomical location. You typically represent a cortex that is depolarized, and your dipoles typically go deeper in a white matter. So when you see a dipole model, the dipole usually is in the white matter, not in the cortex, because it's the representation of that cortical activity what it's aiming to. So both are about the same. I use both. I use both the dipole model. I use the S-Loretta as the source localization. So particularly the moving dipole model, which is the most commonly used, it gives you a dynamic. If you have a good data, you can have, let's say you start calculating your dipoles from a half or 2/3 of the amplitude of the spike, and then you move it all the way to the peak, so you can see the direction of the movement of the dipole from one area to another. It's particularly helpful when you have, let's say, temporal spikes that move to frontal or frontal area. We have one area of the front that moves to the contralateral frontal area. So this directionality and direction of the propagation of the dipole is very useful to understand the epileptic network.
Questions just keep coming in. So this one is asking, what is the explanation from a network perspective for increased spiking that can be seen during sleep in some epileptic patients?
Well, I think it has to do, remember the spiking have to do with the level of between the inhibitory network versus the excitatory networks. As the cortical networks become dormant, also there's some decrease of the inhibitory network that goes along with it. The lateral inhibitory networks in the cortical network is going to be dormant. That would allow the epilepsy focus to be more active and allow this spike to be present. And you can see a higher synchronization because the EEG in the sleep is more synchronized. The thalamocortical networks allow that. They use the same networks that you use physiologically to spread faster and different areas. That when the patient is awake, the effect of the lateral cortex inhibit or prevent these discharges to spread out. And as I say before, the amplitude is proportional to the synchronization. So it's been estimated that you need at least 10 by 10 square centimeters of cortex simultaneously firing to seen on the scalp. So the larger the area of the cortex synchronized, the larger the amplitude. So you can, since you get hypersynchronization with the sleep, you are more likely to see the spikes, not only more common, but also higher amplitude.
Two more. Why do lesions affect cortico-cortical connections more than thalamocortical connections?
Well, the lesions that this is a not easy to answer question because this is depends on they're vary from patient to patient, depends on lesions to lesions. But normally you will see lesions that affect the cortex versus even lesions the white matter. Let's put it this way, it varies. Let's say you have a patient with a subcortical stroke, the cortex is intact, and all you affecting the afferents of the cortex, the inhibitory afferents of the cortex, then you can have epilepsy due to deafferentation of the inhibitory thalamocortical networks. All right. Now you have an anoxic injury that exclusively affect the cortex and the white matter is intact, then you can have a lateral cortical inhibition that is affected, and that's why. So the answer cannot be given. It is actually happening, depends on the lesion. The nature of the seizure can affect either white matter or gray matter, and depends on the type of network that is affected, then it's going to affect when it causes the epileptic activity. All right.
All right, one more, then we'll let you off the hook. Can EEG wave analysis be helpful in the diagnosis of attention deficit disorders?
So there are things that you could see with EEG analysis that that could potentially be used for that. They're one of the techniques like biofeedback, where you could potentially use your EEG to help the patient improve the attention or the synchronization of multiple areas of the brain. But this is all, you know, I mean, honestly, I don't know much about it, and but I've read something about it that seems to be interesting and potentially useful. If you get to measure, let's say, you know, a frequency, usually with quantitative EEG, you can measure the spectra of an area of the brain, and you potentially do with biofeedback, ask the patient to improve the synchronization of that area by relaxation, and you can see how this area synchronizes better. So you could use this technique to help them improve the attention. But yeah, it's a really interesting, topic. But the problem with this is that it requires very high-end EEG analysis. The major problem with the scalp EEG always has been the contamination. So you get muscle activity, you get movement artifacts, and make this analysis hard to do. But you know, every day we're improving, and maybe perhaps we eventually can use EEG as a tool to help those patients.
All right. Well, thank you so much for answering all of those questions, and thanks to everyone for asking them. There has obviously been a lot of interest in this talk. I'm going to send it back over to Wei to wrap us up.
Yeah, thank you. I totally agree. We literally had 15 questions, Dr. Ochoa. You are just a powerful man answering 15 questions. They are such a great questions, excellent questions. And thank you, Dr. Ochoa, for this excellent presentation. Really explains the important value of the EEG in this epilepsy diagnosis. Really the time information, the temporal resolution, also the network information that EEG can provide is such a powerful tool. So we will conclude today's talk, and we will have recordings available for people registered for this webinar. For our next webinar, we will actually make announcement in our newsletter and also in the social media, so stay tuned. Last but not least, happy Friday. If you are overseas, happy Saturday. Thank you. Bye-bye.
Thank you. Bye.